So next topic is nosocomial infections. 53-year-old patient remains ventilated on the intensive care unit 5 days after the emergency laparotomy for perforated diverticulitis. He is febrile, high white blood count and CRP. Clinical examination reveals no signs of peritonism. What are your initial thoughts about the source of infection? So this is a post-op man, and there are his abdomen is fine, but still there are potential sources which can give him infection. So he can have pneumonia, he can have urinary tract infection, he can have bloodborne infection, he can have collection, he can have wound infection, he can have line infection, cannula and central lines. And why are nosocomial infections important? Because they increase the patient stay in the hospital, they increase the cost, they increase the morbidity and mortality, and they're more common in ICU patients than those in the general ward. And describe the risk factor for the nosocomial infection. Again, patient factors and the environmental factors and organism factors. So patient factors, severe illness, underlying comorbidity like diabetes, jaundice, kidney failure, poor nutritional status, immunocompromised, surgical wound, invasive devices, mechanical ventilation, and prolonged antibiotic therapy for several courses. Environmental factors: poor hand hygiene, inadequate space at the bedside, inadequate staffing ratios. Organism factors: antibiotic resistance and pathogenicity. What is a care bundle and how is one used to reduce the incidence of ventilator-associated pneumonia? A care bundle is a group of intervention that, when all applied together, reduce the morbidity. Mechanically ventilated patient currently aspirate small amounts of oropharyngeal secretions. The cuffs and the tracheal tubes and the tracheostomies cannot completely prevent this. The ventilator care bundle aim to decrease the likelihood of ventilator-associated pneumonia and limit the duration of mechanical ventilation. It includes maintaining the bed at 30 to 45 degree head up, regular mouth care, maintaining the tracheal pressure 20 to 30 centimeter of water, subglottic aspiration, daily sedation hold, and DVT and stress ulcer prophylaxis. How is the diagnosis of ventilator-associated pneumonia made? Diagnosis of ventilator-associated pneumonia is usually made with systemic criteria like temperature and white cells, primary pulmonary criteria, new onset or increased purulent aspirates from the secretion, from the aspirations of trachea or worsening gas exchange. And radiographic criteria as new or progressive and persistent infiltrates or consolidation or cavitation, and positive cultures from the blood or the sputum. Pulmonary secretions are often colonized with the bacteria, and not all positive cultures should be treated. And close liaison with the microbiology team is essential in identification and treatment of the ventilator-associated pneumonia. What bacteria are typically responsible for ventilator-associated pneumonia, and how would you treat them? So they all are gram-negative, like Klebsiella, E. coli, Enterobacter, and Pseudomonas aeruginosa. And the antimicrobial choice will depend on the local pattern of resistance and should be guided by the microbiology advice targeted to the specific organism. Describe the risk factors for central venous catheter infection and methods that can be used to minimize these. So first, 5 to 40% of central venous catheters are colonized with the bacteria. This may occur without causing any morbidity. Catheter-related bloodstream infection is potentially difficult to diagnose and relies on growing the same bacteria from peripheral blood and the central venous catheter in a patient with clinical signs of infection and no other apparent source. So risk factors: femoral has more infection than internal jugular. Internal jugular has more than subclavian. So subclavian is the best. Poor technique during insertion, multi-lumen catheters, poor hand hygiene or aseptic technique used when accessing the catheters, frequent dressing change is not recommended, long duration of catheter is not recommended. Risks can be reduced by using the meticulous aseptic technique using the 2% alcoholic chlorhexidine, avoiding the femoral route if possible, antiseptic or antimicrobial impregnated catheters, review of catheters on daily basis and removal if they are no longer required. What are the risk factors for developing a candida infection in ICU? Candida species are common commensals on the skin, mouth, flora, and the genitals. They are mostly non-pathogenic, but several risk factors have been identified like abdominal surgery, central venous catheter, parenteral nutrition, multiple course of antibiotics, acute renal failure, chronic hepatic failure, prolonged ICU stay, and candida spread from the other side. How is clinically significant infection with the candida identified and how should it be treated? Treatment should be continued for at least 14 days following the last negative blood culture. All isolates from the blood should be considered important. Patient at risk with candida isolated from the two sites. Clinical signs of infection should be presumed to have a clinically significant infection. Antifungal treatment should be based on the resistance profile of the organism, isolated and guided by the local microbiological advice. Removal of existing intravascular catheters may reduce the duration of the candidemia. Fundoscopy should be performed as up to 15% of the patient may have endophthalmitis associated with the candidemia. Thank you.